A 40-year-old woman in Egypt arrived at the hospital with alarming symptoms. She was deeply fatigued.
Her skin was covered in unexplained bruises. Tests revealed a dangerously low platelet count.
The resident, eager to help, ordered a platelet transfusion. "Hold on," the senior consultant exclaimed, recognizing a potentially fatal error. This was not just a case of low platelets, it was something far more complex.
This patient's case presents a classic example of thrombotic thrombocytopenic purpura, or TTP, a rare blood disorder that can be deadly if not treated correctly. The resident's instinct to order a platelet transfusion, though well-intentioned, could have had devastating consequences. TTP is a medical emergency, and understanding its complexities is crucial for timely and effective intervention.
TTP is an autoimmune disease that triggers blood clots in small blood vessels throughout the body. Imagine your blood vessels as a network of roads. In TTP, tiny roadblocks made of platelets and a protein called von Willebrand factor start forming. This disrupts the normal flow of blood and can lead to serious complications. These clots affect vital organs like the brain, kidneys and heart. This explains the range of symptoms we see in TTP patients, from neurological problems and kidney failure to heart attacks and strokes. The low platelet count, a hallmark of TTP, happens because platelets are consumed in these abnormal clots. There are two main types of TTP, hereditary and acquired. Hereditary TTP is rare and results from a genetic defect. Acquired TTP, which is more common, occurs when the body's immune system mistakenly attacks an enzyme responsible for breaking down von Willebrand factor. This leads to an excess of this protein, promoting clot formation. While the exact trigger for acquired TTP is often unknown, several risk factors have been identified. These include pregnancy, certain infections like HIV, autoimmune diseases like lupus, and certain medications. Understanding these risk factors can aid in early diagnosis. Section 4. Diagnosis: piecing together the puzzle. Diagnosing TTP is like solving a complex puzzle. It requires a combination of clinical suspicion, especially in patients presenting with unusual bruising or bleeding, neurological symptoms, and a low platelet count, and specialized laboratory tests. These tests typically reveal anemia, a low platelet count, and the presence of fragmented red blood cells called schistocytes. It's crucial to differentiate TTP from other conditions that can mimic its symptoms. These include disseminated intravascular coagulation, or DIC, and other thrombocytopenic purpuras. A prompt and accurate diagnosis is vital, as delaying treatment can have life-threatening consequences.
Section 5. Treatment: a race against time. Once TTP is diagnosed, immediate treatment is critical. The cornerstone of therapy is plasma exchange, a procedure that involves removing the patient's plasma, which contains the harmful antibodies, and replacing it with healthy plasma from a donor. This helps to restore the normal balance of clotting factors and prevent further clot formation. It's important to emphasize that platelet transfusions are generally avoided in TTP, as they can worsen the clotting problem. In addition to plasma exchange, other medications may be used to suppress the immune system and prevent the formation of new clots. With prompt diagnosis and appropriate treatment, the prognosis for TTP has improved significantly in recent years.